Miss Lindermeyer,
Here.
Mr. Landsman, Mr. Kemp,
Here.
Dr. Hans,
Here.
Dr. Guadalupe,
Here.
Mr. Furman,
Here.
Miss Bernard, I think I've seen her on. You might be muted, Miss Bernard. I see her on, she's just muted. And Miss Summers.
Here. Thank you, Sheila.
Mhm.
Are there any changes to the agenda as presented? Hearing none, is there a motion to approve the agenda as presented?
I'd make that motion, Judy.
All right.
Second,
Nalkaya?
Steve.
Thank you. All in favor, please say aye.
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 Any opposed? The next item is our first opportunity for public comment. Christine, do we have anyone who's signed in?
No, we do not have anyone signed in at this time.
Okay, thank you. We'll check back with you at our second opportunity. At this time, is there a motion to accept and approve the items in the consent agenda?
I'll make that motion, Judy.
Thank you, Nalkaya.
I will second it. Jonathan.
Welcome, Jonathan. Thank you.
Thank you.
All in favor, please say aye.
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 Any opposed? Great, thanks. Our first item on the agenda is our update on COVID-19 from the team.
Okay, good evening, everybody. So just a couple of brief updates. Mine will be short and sweet. I did mention last week or last month, the last time we had an update, that we did have to submit a stabilization plan to the department. We did do that, and we got the response today that it was accepted. And just some ongoing reporting we'll have to do on a monthly basis to make sure that we are continuing to keep the state updated and our network stable. Other than that, I will turn it over to Dr. Lawson for her portion of the update.
Hi, good evening, everybody. I'm happy to say that we did still discharge our last person from Pontiac General Hospital and have had no new people utilize that as a quarantine place. We had another successful round of personal protection equipment delivered throughout the network last Friday and are actively working on a phase 2 of PPE acquisition should we see another surge in cases in our near or near distant future. So with that, I'll turn it over to Diana.
Excuse me. Hello, everyone, and hope everyone's having a good evening. So, we've been talking about how OCHN procured 150 tablets for people that we serve to promote the use of telehealth. When we reached out to our provider network, we actually found that there's a greater need than that number. So while we continue to work on the distribution of those, we are also going to be pursuing grants to see if we can get more funding for technology that people need for telehealth. We do have Easter Seals and OFS have both received grants to help with that as well. We do know that the state is continuing to discuss telemed. We still don't know exactly what it will look like, but they continue the commitment of saying that telemed will continue in the future due to the great response that we've had. As far as reopening, we had leadership return to the Troy building this week. And last Friday, both of our buildings received a deep cleaning, and we continue to refine our plans. I think it's safe to say that every single week, if not every single day, we learn something new about COVID as far as maybe what best practices are as far as cleaning, learning more about the virus itself. And so we will continue to adjust those plans as necessary, including things like what happens if we have an exposure, how will we clean, how will people be notified, all of those types of things. And then we have any staff that are coming into one of OCHN's buildings, or if they are going to represent OCHN out in the community for maybe an audit or someone who works in another building. Everyone is doing a screening form every morning that is being completed where people go through a symptom checks as well as their temperature. If they don't say yes to all of those questions, they cannot report into the office and need to connect with HR. That is all I have for my updates.
Judy, I have a question for Diana.
Sure.
Diana, with the tablets that we secured for people that we serve, are they enabled with Wi-Fi, or do they need Wi-Fi to use them?
Yeah, so they will need, someone will need to have Wi-Fi. All we did is buy the actual tablet.
Okay. So do we know how many people that got them actually have the Wi-Fi to enable them?
So right now, no one has gotten them. We are still holding on to all of them. And one of the criteria that we will use for them to be distributed is that someone will have to have Wi-Fi in order to get a tablet.
Okay, thank you.
You're welcome.
Are there any other questions for Anya, Nicole, or Diana?
It's Sarah. I had a quick question. So you guys know, did the state come through with providing the PPE that they had promised, or is there not? I presume the need is not as great as it probably was in the past, but just curious if we did get materials.
Hi, this is Nicole. Yes, we did get some materials. We've gotten, I think, 3 deliveries from the state. They keep getting kind of smaller and smaller, but they are making sure that we're included in any PPE delivery. We're still continuing to look and acquire it ourselves, though, just to make sure that we have enough for the network.
And to build upon what Nicole is talking about, we want to make sure that we're looking for maybe, and we're going to get guidance from the Oakland County Health Department of having a 3 to 6 month supply of PPE, because what we know, or what we're expecting, is to see cases increase in the fall and winter, and we could even see more cases increase as the economy continues to open.
So will you be requiring, when the building reopens, are folks going to be required to wear masks? And if so, will those be available?
Yep, that's a great question. Everybody who comes into our building and staff, they do have to wear a mask. We have procured a cloth mask for staff so that they have those, and then we will also have disposable masks as well. And we've had a couple of requests where people would prefer to wear a face shield instead of a mask, and we have those available for them as well as hand sanitizer, bleach wipes, and most of the other things that we would expect to help sanitize the building and keep everybody safe.
Great, thank you.
You're welcome.
Anyone else have any questions?
Yeah, Judy, it's...
Vijaya.
Go ahead, Vijay. No, go ahead, Vijay.
I was attending a webinar a few weeks ago, and I remember hearing that Comcast has offering some refurbished computers, and I think $10 or $15 a month for internet connection, with a total cost of about $250 for the year. I don't know if anybody is aware of that or has heard about it.
Yes, we are aware of that. That is something that has been available, and we have that information on our website.
Okay. Thank you.
You're welcome.
Jonathan?
Thank you. Diana, I know that the last time we met, there was some discussion by the board asking to provide some input into the plan for when it comes time for us to make the return. But I also have been monitoring some of the other organizations that I'm affiliated with, and they have adopted some things such as one person in and out of an elevator at any one time. And I didn't know if we were adopting of activities.
You cut out a little bit, but I think your question was, are we limiting those kind of activities? So for example, in 2 of our elevators, we can only have 2 people in them at a time. And we have procured anywhere we know that we need to have, like the elevators are a good example. There are actual stickers on the floor where people would stand in the elevator. We have signs on each of the stairs. One set of stairs is for up, and when the other set of stairs is for going down. So we have been doing those things to try to keep the distance between folks.
Thank you.
You're welcome.
I had a question on the check as people enter the building. Once you open up more, are people going to have a temperature check as they come in the door?
Well, our building is closed until, the plan is until September 1, but what we do have is if, for example, if a vendor didn't do a check with their organization, with their employer before, we would do a temperature check before they come in. And we do anticipate, that being our future opening plans as we continue to allow more people into the building.
Okay, thank you.
Other questions? I've got one. I just wonder what it is, what's the protocol for making sure that we catch any new wave of the virus early? What are we doing within the people we serve?
Well, I think one of the really good things is that we still have, telemed is one of the things that is obviously going to help with that. Having people not come into our buildings. All of our providers are, everybody has PPE available for people, and the same thing for us. So we don't have the order in, but we have ordered 20,000 cloth masks, and ensuring that we can get people a mask if they don't have one. When our diagnosticians, when they do assessments, they will also be able to give people masks if they don't have them. So really being able to give people things that they may not have, which once again, sometimes it might be, as simple as a mask, and ensuring that they have those. And then that is one of the reasons why we have chosen to keep our building closed and to keep as many people at home for the time being, is to help also the spread among our staff.
Okay, thank you.
You're welcome.
Other questions? Well, thank you for your presentation. It's always informative, and I'm glad that we seem to be on top of things right now. Hope that continues.
We do too.
I'm sorry, Judy, I had another question.
Okay, Malpaca.
I'm just wondering, because we all know that not everybody is wearing masks. So if someone comes to the building and they're not wearing masks, what is the protocol for that?
So if we were to have a visitor come to the building who's not wearing a mask, we would have them leave. So let's say a parent came in and said, I can't tolerate, a kiddo, or I can't tolerate wearing a mask. We would work with them, either have them go outside. The other thing that we've done is, because, for example, we know the kiddos that the diagnosticians are doing assessments on, they can't wear masks. So, for that one, what we've done is we've given them, they're going to have masks that are see-through with the mouth. They've got like a piece of vinyl over them and a face shield. So for some of those where if it's not if it's like a medical reason why someone couldn't wear one, we would work through how can we do it. If it's a preference, then, those are folks that we're just going to say, you can't be in the building. We really need to enforce mask.
Okay, thank you.
You're welcome.
Other questions? Okay, thank you. Appreciate the update. Next item is the April 2020 financial review. Anya?
Okay. So the April financials are finally to where you can start to see some of the things we have been talking about related to revenue. So you can go ahead and go to the first chart, Christine. So you can see April there being the one with the blue spike. So the reason we're seeing that blue spike is because that was when the retro rate adjustment was done for the fiscal year 20 rate adjustment. So it was about 2.5 million adjustment to the rate, which we expected, and then that will be going forward in future months. The other thing we're starting to see when we drop to the next chart is you'll see that the eligibility trend is starting to tick up quite a bit. So you can see at the time when this was run, the very early May numbers were higher than previous months. And remember, that's very early in the month, and these things add up over the month. So April was definitely significantly higher than prior months, and we will continue to see that throughout the remainder of the fiscal year. Christine, can you go to the eligibility trend next? So if you look here at April, so April is a good example of where you can see the difference between the eligibility trend hasn't changed drastically, but the revenue did. So that would indicate it's a rate adjustment, not an eligibility caused increase in revenue. As we go forward, you'll see next month, the eligibility trend, which I did send you guys a snippet of in one of your last updates, it is increasing quite a bit. It's higher than we've seen in a very long time and continues to go up just with the state of the economy at this point and unemployment rates. So we're going to continue to see that go up, and that has a positive impact on our revenue. You can go to the next one, Christine. So what that means from a balance sheet perspective is you can see cash and investments is going up. Hang on one second there. Now I can see it. Cash and investments is last month you would have noticed a much bigger difference between these two, where last fiscal year was higher. We're starting to catch up now. We've roughly cut that in half between March and April, and now going into May, we've made up the majority of that. And then with the June payment, I do expect that to be pretty much made up. You can see receivables have gone down a bit. That just means we've started to collect some of those things. Some of the year-end provider cost settlements have been collected. That just takes a little time. Other assets have gone down just slightly. That's depreciation and those types of things on the building and any capital assets we have. And then to the right is specifically capital assets, which is primarily the building. The two different buildings have gone down just slightly over the month. Okay, you can go to the next one. So liabilities, you can see have gone down pretty significantly between the two time periods. So if you're looking at the green one, that's September 30th. So typically on September 30th, that's when we've done all of our accruals for the remainder of the year, trying to make sure we have everything booked so that the audit can start getting going. So what you can see is now that we're officially, April is 7 months into the year, you can see those starting to go down. So that's as we start to pay those liabilities off. If there were providers that we owed money for cost settlement, those types of things are now being processed and getting those off the books. So those things will continue to go down comparatively to the end of the fiscal year. And then due to state, what that is typically the state facilities. So what we do is accrue that every month, our portion of state facility expense, and then just depending on how frequently they bill us, we're able to process those. But sometimes you'll see like this month that they must not have billed us this month, and so we did an accrual, or the portion of things like the county match and those obligations to the state get accrued, and if they don't always get paid every month, sometimes they're paid on a quarterly basis, and sometimes they're paid on a monthly basis. Employee payables, you can see, is just slightly higher, and I still have not remembered to ask specifically what's in that, other than maybe it's the PTO accrual. I can't remember specifically. And then long-term debt, you continue to see that go down just because that is long-term outstanding debt related to the Resource and Crisis Center building, that bond that we just refinanced through the county. Moving on, Christine. So net position, we're at roughly 74 million, just under 75 million in assets. Total liabilities are at about 28 million, making our net position about 46 million. So that was what I got a couple of questions from one of the board members just on our overall net position. So our net position currently is about 46 million. And so that's after you take into account all of the prior year deficits and things like that. And just an update related to the audit, we do expect that to be done by the end of June. So I would expect a July presentation from our auditors, just stating how the audit went and any issues, concerns, or things like that, and our financial position at the end of the fiscal year. So one of the other questions that was included in the list of questions was related to the amount of reserves we are supposed to have, allowed to have, and currently have. So I answered the currently have question. It's roughly $46 million. We are allowed to have up to 7.5% of current year Medicaid revenue. So that would be any Medicaid fund source. So they will not give us a recommended amount because they don't do that in a managed care contract. It's up to us to determine that and us to figure out how to fund that within our current capitation. But we are by contract allowed to keep up to 7.5%. Moving on, I think that was all of the questions I had, other than just when we get to expenses, I'll address the other one. So you can see revenue has gone up significantly compared to the last fiscal year. And so that's to be expected based on the rate adjustment we saw at the beginning of the fiscal year and in April specifically, along with the eligibility trend. So we should continue to see that for the remainder of this fiscal year. You will see that continue to go up. General fund is roughly the same, just slightly less, which would typically be the expiration of some sort of grant or COFR agreement, which would be a county financial responsibility. So those types of things impact general fund. County fund, you can see, always stays exactly the same. They pay us the same amount every month consistently for the past 15 years. And then all other revenue has gone down slightly. That's going to include grants and things like that that have just expired and or been reduced. Okay, moving on to expenses. So you can see administrative expenses has gone down. Part of that has to do with how we categorize things differently than we did prior. What you can see is provider network expenses has gone up. And so one of the questions I did get was, is now the right time to be increasing provider spending? And so the way our system works, our spending is really based on need. It's not based on just the desire to spend more. It's based on what services people need, how often they need them, and those types of things. It's not really based on just a choice to spend money. That's why if and when we do have to reduce expenses, it becomes very difficult because all of these services being provided are considered medically necessary. So when expenses go up, part of that has to do with things like hospitalizations or an increase in need for a particular population or an expansion in a service array or something like that. In this particular situation, not only have we seen hospitalization expenses go up a bit, which to some degree is related to the number of hospitalizations, but also has to do with the hospital rate adjuster, which is it's a complete pass-through from the state. They fund us the exact amount we push out, but they did increase that in this fiscal year. So that is playing a large part in the increased expenses. As it relates to grant expenses, you can see those are a bit lower than in the prior year, but that's really just because some of the grants went away that we had in prior fiscal years, and some of them, the one we've talked about several times, the Clubhouse grant has been reduced to be a more appropriate amount so they can spread that around a little more. And then all other you can see is roughly the same within a couple $100,000. Okay, you can move on, Christine. So you can see net income is total revenue is up from the prior year, as well as total expenses. And you see that net loss there. We've pretty much made up for it through April, and you will see that continually gaining as a positive number in May and June, and that's something you'll see just based on the revenue that is now coming in, and also the eligibility trend will have a material impact on that through the remainder of the fiscal year. So with that, I think that's the last chart off the top of my head. Oh, we just have the provider chart, and I did get a question related to the autism providers, and because those are not specifically listed here because they tend to be a little bit smaller in comparison to our larger providers. So we can either send a list of those autism providers, or we can, we're scheduled to go through the budget, the draft 21 budget at the study session, or I can show it then or give an actual list based on preference. So with that, I believe that is the last chart. So I can take any questions.
Are there questions for Anya? Oh, you must have done an outstanding job.
No, for once I have good news. So, you know, it happens few and far between. So
Yeah, that goes down pretty easy. That's
right.
really good.
Right.
Okay, we'll move on then.
Thank you. Okay, looks like I'm up again.
We're going to discuss budget amendment 1.
Yep. So this is the document we reviewed at the committee of the whole. This will be an item for approval this time. So this time we do actually have the documents that are after this. I will walk through the revenue adjustments, show you the chart, and then we'll walk through the expense adjustments, show you the chart, and then show you the total impact on fund source balances and things like that at the end. And then I will ask for approval for this budget amendment. So this budget amendment is this is the first one we've done since we did the initial draft budget, which was done back in August of last year. And so a lot's changed since then. We've had all these challenges with collecting revenue and all those types of things this fiscal year. And so we're finally to a place where we feel like we can put some decent amount of parameters on what's happening and what we expect for the remainder of the fiscal year. So what we saw is revenue increase from the original budget amendment by about 1.9%, or roughly just under $6 million. So part of that is going to be the direct care wage increase that was implemented for that 3-month period. It's going to be the eligibility trend that we're starting to see. We also had a COVID-19 grant from the department that was roughly $230,000 that we are using to cover PPE and those tablets that Diana just talked about us purchasing. We did see a reduction in our grant revenue. We talked about that a bit, related to several grants expiring and our clubhouse grant being reduced to a more realistic level of what's actually being spent in the prior years. We did increase tenant revenue. Based on the now signed lease with OCHN, which you will have as an approval item to do the build out for that later on tonight. So we did build that into revenue. So the overall change in revenue is roughly $5.5 million to the positive. So that's good news. So you can move on to the next slide, please. So this is what it looks like from the budget amendment document you're used to seeing. So this is just the top half with revenue. So all of those things, this is the result. All of those adjustments that I just talked about, this is the result of what the budget now looks like with those adjustments. So moving on to the next slide is expenses. So the adjustments to expenses included several different things. So as I mentioned just a few minutes ago, our expenses are really based on need and the needs of the population that we serve. And so we go into the year with assumptions on what people will be utilizing throughout the year. And then partway through the year, we go through and recalibrate all of that. So what that meant was we had to make some adjustments to expenses for core providers. Those did go up a bit. We also had to make an adjustment to crisis and acute care, which is related to hospitalizations and that HRA payment that is a pass-through that I talked a little bit about. We did make a slight increase to the children's waiver population and the substance use expenditures based on the number of individuals being served in both of those particular categories. So those have gone up, which then increases the expense. So the direct care wage we talked about in revenue, and so now you're seeing it on the other side here with expenses of $2.7 million. And so overall, the expenses increased by about 2.1 in total, for a total change in net assets to be a surplus of around $3 million. So if you can switch to the next slide. Okay, so this is the bottom half of that budget document that just shows you the expenses and then shows you the total change from in operations, which is about $4.4 million. So that is primarily the planned amount to be in excess of expenses. So I'd like to go to the next slide, which talks a little more specifically about fund sources, because that's really how we manage the money. So this is a document we use quite frequently just to help explain really what fund sources are allowed to be commingled, what ones aren't, and how that really ties in together. So if you look at this top section here, this is all the Medicaid fund sources. And before we get to our next amendment, we will move up both children's waiver and SED waiver, because those are now considered capitation fund sources and will be included in Medicaid fund sources, both from a revenue and expense perspective. We just didn't do it this time. So what you can see is excluding those two things, I would call that break even on a $300 million budget. We're at a deficit of about $281 million projected for the entire fiscal year for Medicaid expenses. So for us, that's amazing. So if you guys think back to the last 2 fiscal years, we had material deficits in Medicaid. But as we knew what was coming, we knew they were working on rates. We knew they were working on a new way to distribute funding and those types of things. And so we knew that that was going to impact us to the positive, and that's what you're now seeing. You're seeing we're roughly at break even from a Medicaid perspective. Now, if you add in children's waiver and SED waiver, it doesn't have material impact. It actually lessens the deficit just slightly by about $23,000, so it doesn't change it a whole lot. So when you look at the next section, the other mental health, so again, that's our other fund sources that are a little bit different from Medicaid in that they can't necessarily, they don't necessarily commingle the same way. So general fund, that shows what I would consider break even on $11.7 million. Local is something we get from the county that typically we do have a surplus of. You can see this year we're projecting about 1.4 million. Skipping over children's waiver and SED waiver because I already spoke about those. Grants, we always book those as break even from a revenue and expense projection because that's what the expectation is with a grant. And then non-MDHHS is the partnership we have with our local federally qualified health plan that we help fund the co-located sites they have with core providers. So all of that mushed together is a surplus of about $1.4 million. So when you drop down to this next section that says other substance use disorders, so that's the non-Medicaid substance use funding. So PA2 is the fund source that we've talked about. It's just slightly more restrictive than local money in that it cannot be used for administration, but it can be used for services and has very little limitations from that perspective. So that fund source we do typically have a surplus in. That's expected to be about $2.7 million. Block grant we're expecting, which is the substance use equivalent to general fund, expected to be a surplus of about $500,000. The STR grant is a very specific substance use grant as well as the SOR grant. So all of those things combined is a surplus of about 3.3 million. So again, all of those combined is where we get the 4.4 million. So in total, we will be at a surplus of roughly 4.4 million, primarily from substance use PA2 funding and local funding. We're at about a break even here for Medicaid, but again, as I mentioned, I do expect the Medicaid revenue to continue to increase over the remainder of the fiscal year based on the current eligibility trends. So with that very long-winded version of Budget Amendment 1, I will take any questions and or motion for approval if you all are ready.
I would move to approve it. This is Pat.
Thank you, Pat.
It's Sarah, I'll second.
Are there further questions or discussion?
I have a couple of questions, please.
Okay, Jonathan.
All right, just to make sure I understand this. So right now, it looks like we are, with this budget amendment, increasing the amount of revenue. We're making the adjustment to show we're going to have an increased amount of revenue, but also an increased amount of expense. Is that correct?
Yep.
Okay, but based on this and the revenue expectations for the rest of the year. And it's, even though we're only looking at through 7 months here, we're already almost through 9 months of the year, right?
Yep.
So we've actually started to receive, well, we really have received last month's payments. We haven't gotten June's payment yet. But
Nope.
okay.
But we have received May's, and it is the highest of capitation payments we have received year to date.
Okay. So with all that in mind, do you think that we're going to end up at an even Stevens, rather than a deficit of $1.6 million coming out of reserves, that we might actually be putting additional monies into the ISV, the reserves?
So I don't have a deficit at all, other than this 280,000. So
Okay.
we'll be in the positive regardless, to answer your question. So what we have not really booked too much for is the eligibility trend that's happening, because I like to see that play out a little longer, especially because this happened so fast, where it really flipped on a dime.
Yep.
We had been seeing decreases for years, and all of a sudden I've seen it's higher than it's been in 2 years. So we didn't really put much of that into this revenue projection yet, because I'd rather play that a little more conservatively, because we don't want to just necessarily bank on it yet. We want to see how it plays out, because the financials do take a little bit of time to catch up, and coming off 2 deficit years where we spent, close to $40 million, it's important for us to be conservative from a revenue perspective. So I do expect the numbers to ultimately end up better than this, from a revenue perspective.
Okay. Have we heard anything from the state in terms of, other than the worry about their significant budget deficit, if that's going to have an impact on us?
So we have not heard anything at this point. The only thing I know that is still outstanding, which we are getting questions on pretty regularly, is are they moving the $2 increase to $3 and or extending it? So that has been a bill that is with the legislature, and if that happens, obviously that would have an impact on both our revenue and expense, but I've not heard that either way. So that is the only adjustment I have heard at this point that is potentially on the table. So I don't know of any other adjustments, either to the positive or negative, that we would be seeing.
Okay. And with that in mind, with that wage increase that we've passed on to people, if they back that out for next year, we'll either have to back it down too, or dip into our reserves to cover that, right?
So we are only implementing it for the time period the state is implementing it, for the most part. So they only did it for April through the end of June. We started it a couple weeks earlier, but we are not continuing it past the date they ended the funding.
Okay. So that's just sort of like, I'm trying to remember what they called it, because the working conditions,
Oh yeah,
right?
yeah. I think they were calling it premium pay was the term they were using. We used enhanced compensation. We were just trying not to call it hazard pay, because that just had a kind of a negative connotation to it. It was really more to appreciate and recognize the hard work that the people serving people face to face were really
Right.
doing during all of this.
The old days, we would have called that combat pay, but yes.
We were trying to avoid some of those terms. So
Yes. Okay. So those are my questions. I just wanted to make sure that was really clear for people.
Get a coffee?
Are there other questions for Anya regarding Budget Amendment 1?
Well, it's not really Budget Amendment 1, but I'm listening to the projections, Anya, and I know all of this is pre-COVID. So even though, hearing the increases and the way that the budget seems to be going now is good news, but we haven't hit the COVID expenses yet. So should we still be optimistic or is it gonna dip?
No, to some degree we have hit the COVID expenses, because understand that direct care wage pass through that we did incorporate into this is the primary expense tied to COVID. So what we did with providers was we continued historical funding, which is no more than we were planning to spend anyway, and continued providing that for stability's sake. And then the only really additional spending was the $2 enhancement, and then also that grant we received that is covering the PPE and the tablets. So we are accounting for that for the most part in this. We are not expecting to see expenses jump drastically, because if anything, people provided slightly less service in this situation, not necessarily more, outside of the enhanced payment for those providing direct direct care services. And that was, the majority of that was covered with the $2 increase from the department.
Well, another question I have too is, since we had to change from the funding models to doing fee for service during this time, isn't that going to affect the outcome at the end of the year for our core agencies?
No, not necessarily. So we switch from the service models to cost reimbursement. So what that means, we're not paying anything over what we would have spent, and in fact, in some cases may spend less because during this time period, they will not be allowed a profit. So typically on a service model, they are allowed to keep up to 2% of that particular service model. During this time period, when we switch to cost reimburse, we take that off the table because then we bear all of the risk. So when we bear all of the risk, we're not allowed to offer a profit. So it will not be material really one way or the other, quite honestly. We are not pushing out any more than we would have pushed out otherwise, except for that $2 that is, 98% covered by that $2 that the department is pushing through.
So are you anticipating our core agencies to be stable at the end of this fiscal year?
Yes.
Based on the projections that you're seeing right now?
Yep. We moved them all to cost reimbursement, so there's no reason they shouldn't be, and we are in regular contact with them to make sure.
Okay, thank you.
Yep.
Other questions for Anya regarding the amendment? Okay, there's a motion to approve budget amendment 1 as presented. Sheila, would you call the roll, please?
Sure. Ms. Newman,
Yes.
Dr. Taub,
Yes.
Dr. Hans,
Yes.
Mr. Kemp,
Yes.
Mr. Landsman,
Yes.
Mr. Furman,
Yes.
Dr. Guadalupe,
Yes.
Ms. Bernard,
Yes.
Mr. Torres, Mr. Lindemeyer,
Yes.
Ms. Namie Dyer,
Yes.
Ms. Summers.
Yes. Thank you, Sheila. We'll move on to our next item, which is the CDWG contract, which is also an item for approval. Diana.
All right, so this is the approval from last week when I went over the CDWG contract or agreement. This is for all of our Microsoft licensing for servers, databases, and Office 365. This is for the 3rd year of that agreement, the payment, and it is in the amount of $212,800. Let's try that again, almost $213,000. So that is the request that I am making to the board.
Are there questions for Diana regarding this contract? I'm not hearing anything. I'm going to proceed then. Is there a motion to approve the CDWG contract?
I'll make that motion, Judy.
Thank you, Malkaya.
This is Jonathan. I'll second that motion
Thank
for
you,
the
Jonathan.
contract approval.
Sheila, would you call the roll, please? Are there further questions? Let me make sure that everybody has their questions answered. Okay, Sheila, would you call the roll, please?
Sure. Mr. Lindemeyer,
Yes.
Ms. Namie Dyer,
Yes.
Mr. Torres, Ms. Bernard,
Yes.
Dr. Guadalupe,
Yes.
Mr. Furman,
Yes.
Mr. Landsman,
Yes.
Mr. Kemp,
Yes.
Dr. Hans,
Yes.
Dr. Taub,
Yes.
Ms. Newman,
Yes.
Ms. Summers.
Yes, thank you. Our next item is the, again, an item for approval, and it's the ACHC build out, and Patrick going to present.
Okay, We're presenting the build out for the Freedman Premier. We presented the information to you on last meeting that we're seeking $267,000 build out for a 15-year lease agreement. And so we're asking for the board to approve this contract.
Okay, thank you, Patrick. Is there a motion to approve this contract?
It's Sarah. I'll make the motion.
Thank you, Sarah.
Steve, I'll second it.
Thank you. Are there any further questions for Patrick regarding this contract?
This is Jonathan. I have one.
Sure.
Do we have an anticipated move-in when revenue actually start changing hands and come to us for rent?
Yes, we looked at the numbers, and based on the rent schedule, after the 31 months, it's a 180-month contract, 180-month lease. After 31 months, we will break even, and off after for the remainder of the 150 months will be it'll be revenue.
Okay, so 31 months for break even. When do we anticipate month one?
October 1.
Oh, cool. Somehow I missed that. All right,
Yeah.
That's probably me. Thank you, Pat.
Okay.
Are there other questions for Patrick before we take the roll to vote?
Yes, Judy, I just had one. Patrick, could you give the amount of the contract again, please?
The build out cost is $267,000.
And that's the total cost?
The total cost of the build out, yes.
Okay, thank you.
Judy, I have to apologize. I called you Pat. It's Patrick. I'm sorry.
You can call me Pat.
Are there other questions for Patrick? Okay, there's a motion on the floor to approve the ACHC build-out contract. Sheila, would you call the roll, please?
Sure. Mr. Furman,
Yes.
Dr. Guadalupe,
Yes.
Miss Bernard,
Did you call Bernard? I couldn't hear you.
Yep.
Yes, sorry.
Oh, no problem. Dr. Torres, Mr. Torres, Mr. Lindemeyer,
Yes.
Miss Namie Dyer,
Yes.
Mr. Landsman,
Yes.
Miss Newman,
Yes.
Dr. Taub,
Yes.
Dr. Hans,
Yes.
Mr. Kemp,
Yes.
Miss Summers.
Yes. Thank you, Sheila. The next item is another action item, and it's the Riemann contract approval. Anya?
Yep. So I reviewed the details of this at the committee of the whole, but just to refresh everybody's memory. So this is the consultant we brought in after the person that was in one of my director level positions on my team vacated just prior to the 2018 state reporting time period. So for clarification, this contract is a 2.5-year contract. So the adjustment to the not to exceed up to, I believe it's $312 off the top of my head. I did write that down somewhere here. Is for a 2.5-year period that is completely covered by the vacancy in that particular position. But that has been to help revamp the whole state reporting process, revamp our general ledger process, and then also to help fill in while I was helping fill in for the CEO position. So again, fully covered by the vacant director level position. And I expect it to be ending by March 31st of next fiscal year.
Is there a motion to approve this contract?
I'll make a motion to approve.
Thank you.
And I will second it.
Thank you.
Jonathan.
Are there any additional questions for Anya on this contract? Okay, Sheila, would you call the roll, please?
Miss Newman,
Yes.
Dr. Taub,
Yes.
Dr. Hans,
Yes.
Mr. Kemp,
Yes.
Mr. Landsman,
Yes.
Miss Namie Dyer,
Yes.
Mr. Lindemeyer,
Yes.
Mr. Torres, Miss Bernard,
Yes.
Dr. Guadalupe,
Yes.
Mr. Furman,
Yes.
Miss Summers.
Yes, thank you, Sheila. Our next item is the ORR customer service overview.
Great. This is Vicki Suder. I'm the Director of Rights and Advocacy, and we're excited about presenting what our department does in order for OCHN to meet its mission, values, and vision throughout the year. Next slide. This is where we are in the organizational leadership chart. I report directly to the CEO. This is required by the Mental Health Code that the Director of Rights has to report directly to the CEO of the organization. Next slide. And this is our team, customer service as well as recipient rights, the individuals that help us make things happen each day, that support individuals, have individuals' voices heard. So this is our team. Next slide. So the Rights and Advocacy Department is made up of two teams, customer service, which is managed by Mike Daly, and also recipient rights, which is managed by Gene Fentner. And they, a little further along in the presentation, they'll be presenting about their teams. I also wanted you to be aware of that the Rights and Advocacy Department has a couple other things that they do in order to support folks that we serve and folks that we serve in employment as well. We do have a wellness center attendant. That is somebody that works 2 days a week in our wellness center when it's open, and greeting guests and having people sign in and make sure all the appropriate documents are completed. That is what is called a TE position. That's a temporary employment position through a clubhouse that allows individuals attending the clubhouse to get work experience and to have that on their resume and then be able to go into other types of employment. We also have 3 individuals that we contract with that actually go into group homes and do some basic trainings about person-centered planning, recipient rights, dignity and respect. We're very excited. We've been doing that for several years. Very excited that we're actually able to bring those trainings from people who have lived experience right to people that live in our residential settings. And then we also have a contract with a peer support specialist who helps us do trainings for peer support specialists, as well as we have contracted with her to be an independent facilitator for individuals that choose to do that as part of the person-centered planning. So overall, our responsibilities are to advocate, provide information, protect rights, be our agency's ambassadors, and just help individuals' voice to be heard and help them navigate the system. Next slide. So this is one of the our fiscal year 20 strategic plan, one of the ones that I'm responsible for, and it comes under the advocacy and empowerment section of the annual plan. And the goal is civil rights and supported decision making, and this is related to guardianship and having individuals be supported to make decision versus a court-ordered guardianship. So we're looking to decrease that. There was some presentation on that several months ago about where we are with that. We do have a work group. We do meet monthly. I am also part of a state work group related to this. It is an effort that will take several years for us to make some groundwork on that, but little by little, we want to be able to change and inform people about supported decision making. Recently, we were able to update all of our guardianship information in the OCHN system, so that's going to give us some good data to work with to see where we're at with that right now, and then to see where we are with that in the future. And we're looking to decrease the number of persons that are supported by guardians. Next slide. All right, and this is going to be the overview for the recipient rights team, and Jean Fettner is going to take over.
Thanks, Vicki. I'm very excited to be able to talk about the ORR this evening. Besides Vicki and I, we've got 14 full-time and 1 part-time rights staff, which consists of rights specialists and support specialists. In addition, we also have a couple volunteer group home monitors. The team is a phenomenal team. They're very dynamic. They work incredibly well, both with internal and external stakeholders. And we really are looking at our initiatives. And we really do want to empower people to understand and advocate for themselves, understand their rights and advocate for themselves. We're most known for rights investigations. We do reviewing incident reports. We make recommendations. We have an appeals process that we are responsible for. And we're also responsible for training and educating individuals receiving who are being served, our network providers, and other stakeholders. Have the next slide, please. So there are 3 things that I really wanted to talk with you tonight about. Investigations of allegations, training and ed, and our ongoing monitoring responsibilities. Next slide. So one of the things, as I already said, we are most known for our investigations of allegations. And this is really about protecting the rights of the individuals that receive services throughout our system. We investigate allegations of violations of the legal rights, of anybody served by OCHN and its service network. We do have some limits to our jurisdiction. The alleged rights violation has to be covered within the Michigan Mental Health Code or the administrative rules, legislation, so for example, civil rights, the MDHHS contract, etc. So whatever is being alleged has to do with one of those elements, one of those things, all right? Complaints can come from anyone, and they do, all right? We get many, many complaints, from individuals served, but also from their families. We open up our complaints at the ORR with incident reports that come in. Staff will file complaints. One of the obligations that we have within our system is that if somebody wants to file a complaint and they need assistance doing so, that staff must help them with that, even if it's against them. To do all of this, we have 10 rights specialists, and they are working within territories. So they have assigned territories within Oakland County, and this really does help them develop relationships with individuals receiving services, as well as the providers. So they know what's going on within provider organizations. They do friendly reach outs regularly, and just sort of see what is going on with providers and how are individuals within their territory doing. So if I could have the next slide, Christine. The second obligation or responsibility that we have is in training and education. And one of the things that the Rights Office does do, and I think we do well, is collaborate with other teams within OCHN. Everybody has their areas of expertise. So one of the things that the Rights Office is responsible for, however, our training department does the majority of it, is to do the initial recipient rights training for all covered staff, contractors, volunteers, interns, students, whoever who are working within our system. This is a 4-hour training. The content is dictated by MDHHS's ORR. All right, so those 4 hours are packed full of valuable content for the staff and everybody else. Certainly family members and individuals can also attend those. OCHN also requires annual update training. This is an online training. Each year, between live training and online training, we serve thousands of individuals. And the training department is giving kudos for their work with that. As Vicki already mentioned, we also have group home trainers, individuals who go out into our service sites, primarily group home, who have lived experience. And they do talk about person-centered planning, dignity, respect, but also about how to be advocates and how to know about your rights and how to exercise your rights. And then one of the final things that we do is we have opportunities to go and do ongoing education and in-servicing by both myself and our rights specialist. So when we see that a provider needs a little extra help, or if they request extra help from us. So for example, we do quite a number of incident report in-services for staff. How do you do good incident reports? I recently, well, pre-COVID recently, went in and talked about the rights process with one of our providers. So we have that as an option for our rights specialists to go out and to talk to people, all right, and organizations. And Christine, the next slide, please. The third responsibility that I wanted to chat about was our ongoing monitoring. We have a lot of responsibility given to us by the Mental Health Code and contractually related obligations. And so we also work collaboratively, once again, besides with the training department, who give us data, with our quality assurance team. So ongoing monitoring, what does that entail? Well, incident reports are a major effort within the rights office. We get over 20,000 incident reports a year. Every one of them is looked at by a rights specialist. So the incident reports go to the people who have that particular organization or who are serving that particular individual in their territory. They code according to the state codes, and we track themes. We look at what is going on within individual providers, what is happening with individuals, and then we can utilize the wealth of knowledge within OCHN, such as our clinical team, our provider network team, and that to really work with identifying how can we solve some issues. Complaints. We monitor complaints, both substantiated and not substantiated complaints. And this is one of the things that we have to report semi-annually and annually to the DHHS ORR office. So the complaints, once again, we look at for themes. What is going on within provider organizations? Have they taken responsibility for trying to or correcting issues, right? We also, related to substantiated complaints, we're obligated to look at remedial actions. And when we have a substantiated complaint, the provider organization owes us a remedial action. And that remedial action basically has two parts. What did you do to fix what just happened? And then how are you going to prevent it in the future? And so the remedial action is actually incorporated into the summary report. And we monitor whether or not they were actually, the tasks that they said they were going to do were taken, and whether or not they were taken with good intent and doesn't seem to have corrected the issue. We also conduct site visits. This is something that we have to report on annually. Our quality assurance team does the vast majority of these. And these are all of our service sites, including our contracted hospitals. They go out and visit every site at least once a year. Some sites get visited more, including by people like me and the rights specialist. And the site visits are reported out monthly to the Recipient Rights Advisory Committee and are incorporated within our departmental annual report. All right. However, within the site visits, there can be themes that emerge. And so we do have mechanisms within OCHN for tracking those themes and ensuring that they are going to be addressed. And then finally, we've got our volunteer site monitors, persons with lived experiences, and that who can go out and look at sites and talk to individuals who are receiving services to assess, how they're feeling about their rights protection, but also how they're feeling about their services. So next slide, please.
Right.
So we'll take some questions at the end, but I'm going to turn it over now to customer services.
Thank you, Jean.
Yep.
You on, Mike?
How about this? My name is
There we
Mike
go.
Bailey, and I'm the manager of customer service. Initially, I was going to say if I'm talking too loud, it's because I'm yelling into this computer. So someone give me a hands up if I'm talking too loud. Customer service, as noted, there's 11 staff. I have 5 customer service specialists, 2 full-time receptionists, 3 peer allies, and 2 additional positions that help with our goals and orientation, and also shared with the complex case management. So of my part-time people, 5 of them, 2 are 20 hours, 2 are 15 hours, and 1 is 5 hours. Our goals and our responsibility is the call center, which is the main 800 line for customer service. Also the front desk, which is the first floor, and the transportation grants. Both transportation grants are housed in customer service. Grievances, which are also known as complaints, questions, issues, and concerns that are brought to us, whether to customer service or to OCHN itself. The orientation to the public mental health system, meaning letters and personal contact to people who enter our system, welcoming them and answering any questions they might have about the mental health system in Oakland County. And also we do a follow-up, I don't want to call it a survey, it's more of an interview, some short questions after they've completed their intake process at the individual core provider agency, which is very helpful. And through all of this, we track themes and trend information with our work along with the quality management team. And most importantly, we also gather the input, feedback, and concerns from stakeholders, not just the people that we serve. We take phone calls from taxpayers, school staff, sheriff's departments, police departments, protective service, the department in Lansing itself, and countless elected officials, both at the state level and the local level, that have individual constituent concerns. We also are unique is because we can take anonymous phone calls, meaning someone does not have to identify themselves about a concern, complaint, or issue, or even a question that they might have, which we find really helps gather information from the people who are trying to understand the public mental health system. Next slide, please. As mentioned, the transportation is the 2 different grants. One is a block grant at the department. The other one is a 5310 grant. As mentioned by Anya earlier, the transportation 5310 grant did end, so that funding ended. And we look forward for people's feedback soon. Within days, the transportation draft report will be going out for comment for a good 3-week time period, and then it will be formally presented to the board in the July board cycle. So we're looking forward to that. The second one is a very sad situation. This block grant, it was a 1.5-year block grant. We were moving along pretty well, not as far as I would have liked to have seen, and then COVID-19 hit, and it literally screeched to a halt The very few people who are on that voucher reimbursement are still with that program. All our efforts with, we had 2 different vocational service providers going out with people we serve to the police departments and offices that provide mental health and substance use. All that came to an end. So I am really frustrated and discouraged by that, as you can imagine. Okay, next slide, please. So the roles, the primary roles and responsibility are threefold. The customer service team itself is a liaison for the community and the provider network and the people that we serve. Number 2 is also the front desk. I like to say, everyone, that customer service has part of the 4th floor, and the entire 1st floor is because everyone on my team is very familiar with the 1st floor and helping with guests, tenants, meetings, etc. We work very closely with facilities team. And the 3rd one is, again, the feedback and input and communication from all stakeholders, whether that's through the website, emails, obviously the phone calls, letters. Now we're getting into texts and chat. And but this is our primary audience, is the people and the family and visitors to the building. Next slide. Okay, a little bit more detail about each of those 3 roles. They're pretty self-explanatory. I just want to highlight that the how is, again, responding to the any way or any manner that information comes to OCHN or customer service is dealt with. And it says daily, 8 o'clock to 5 o'clock. Even through the work at home situation, I am proud to say the front desk phone and customer service has been answered by a real person from 8 o'clock to 5 o'clock without exception. And the other part of this is we have a direct connection with the email inbox, meaning when people put comments or concerns expressed on our OCHN website, it comes to us and we delegate it amongst ourselves for follow-up. So all roads kind of come to customer service. Next slide. The 1st floor ambassadors, we have 2 people, Shanice Grossen and Valerie Spavin, that their job is to answer the main phone line and assist however needed or whenever needed for the 1st floor and act as lobby greeters. They create this friendly and welcoming environment for everyone who comes to the building. The phones are answered quickly and people are greeted in a warm and professional manner. Again, this is 8 o'clock to 5 o'clock. And this is, again, by Shanice and Valerie. Next slide. Number 3 is the information is power theme in our rights and advocacy team, is that we do our best to get information to people who are asking, requesting information, even information that is not specific to the mental health system. We take pride in having a working knowledge of Social Security, how food stamps work, how applications work, Healthy Michigan, all these other systems that other people that we work with depend on so importantly. And we also, as mentioned earlier, about the orientation process and the interviews for people who are new to OCHN. We're excited about that project. And our team, I wanted to highlight that after hours, not everyone who has a concern or a question can call us between 8 o'clock and 5 o'clock. So we have it on our brochures and we have it in our voicemail message that if a person needs after hours, including weekends, please let us know when a good time would be to contact you, and we will contact you after 5 o'clock or before 8 o'clock, again, even on weekends. And there's the list of the entire team. And that is it for customer service.
Thank you, Mike.
All right, thank you.
So our funding source is where our funding comes through the administration expenses as well as the grants that Mike had mentioned. Next slide. The way that we impact people, we're really focused on the individuals that we serve to make sure they have the information and knowledge and the avenues to have their voices heard. And I'll talk a little bit more about that in a second. We're looking to strengthen the community's understanding by going out and providing information about the public mental health system or taking calls or emails. And then we give individuals avenues through various work groups, conferences to have input in the direction and review of what OCHN does. So we work very hard to help people be a part of our mission and values. How do we impact, again, persons served? So these are the number of work groups or committees that our department oversees. The first two, the CAC and the RAC, are the only ones that are required by contract or the mental health code. The other ones are groups that our organization have put together because we value the input of the people that we serve. Most of these have been in existence for many years. The best work group is the effort that we've had since 2012 to reduce or create a stigma-free culture within our public mental health system. And some of the other things we had mentioned, including transitional employment positions. Mike also has one on his team. So we do as many things as we can, or are looking for new ways to support people that are part of the public mental health system or alumni of the system to be able to have their voice heard as part of the system. Next slide. And service network impact. So we work with just about every team, specifically the provider and the provider agencies to address issues, questions, and concerns. We often, Jean or myself, get calls about rights issues or something that is occurring and want some advice or to talk through the situation. Customer service as well. They get calls from our provider network all the time about issues or circumstances and things they need information about. We provide consultation and training to support individuals that we serve. We hold a couple different conferences for individuals that we serve, as well as I mentioned all the work groups. We provide rights training in partnership with our training department, and we support the different providers through our rights specialists in the territories that they're assigned. Next slide. And our community impacts. So for several years now, we've had a Tri-County Peers Connect effort in conjunction with Detroit Wayne Integrated Health Network and Macomb CMH for many years. So 4 times a year, we do seminars for our peers in our Tri-County area. We usually get 70, 80 peers to those different trainings. And then we also have what's called the Metro Region Peer Certification Collaborative. We do that in conjunction with the MDHHS and related to getting peers certified. We host and put together the training here in the Metro Region with Detroit Wayne CMH. And then we go to fairs and presentations. We are part of the older adults, AAA community response. We are part of homeless healthcare collaboratives, and certainly transportation efforts and initiatives that Mike's been a part of for at least a decade and hasn't given up the hope of resolving some of the transportation issues our individuals that we serve have. Next slide. And then our statewide impact is we are part of a number of different work groups or associations that we provide our information and perspective about what's going on in our community, as well as provider expertise. Next slide. And then what is the legal basis for rights then? It's specifically the mental health code, mostly the Chapter 7 and 7A, although when we're looking at rights investigations, we're sometimes looking at all different chapters of the mental health code. There's also what's called the Michigan Administrative Rules, which are a complement to Chapter 7 and 7A, as well as our contract with the state. Rates is a function of the community CMHSP, so this our Community Mental Health Services Program. So it's not a function of the PIHP. If you were to look at, say, like Lakeshore PIHP, and you looked at their organizational chart, you would not see a rights department there because that is not a function of the PIHP. But if you looked at the CMHs that make up that Lakeshore PIHP, you would see in those CMHs a rights department. Customer services, many of the rules and regulations that govern customer service come from the Balanced Budget Act, also from Medicaid, as well as our contract with the department. Next slide. And now we're open for questions.
This is Eric Lindemeyer. I have a question.
Okay.
When we think about the incident report, do we ever do an analysis or a breakdown by demographic of who's filing incident reports? And then do we look at, when it comes to substantiated versus non-substantiated cases, do we look at the demographics of which ones have been substantiated and which ones have been not substantiated?
Sure, yeah. So a couple different questions there. With our incidents reports, we get over 20,000 a year. Every one of those are read and categorized by our rights specialist, as well as the clinical team reviews those as well. Some complaints are open from incident reports. If there appears there's an apparent or suspected rights violation, we open a rights investigation related to that. Recently, we've developed a dashboard regarding the incident reports. The way the incident reports go into OCHN, it's very difficult to get discrete information in data dumps. So they have created a dashboard, and what it's doing is it's alerting our clinical team if an individual gets a certain number of incident reports in a certain period of time. Now, it might be very relevant, it might not be an issue, but it could be an issue. So it alerts them to that so they can check into it and see what is going on. In relation to the rights complaints, substantiated, unsubstantiated, we do run a report quarterly to see what categories, what providers, what sites those substantiations are occurring, and to see if there's any trends, if there's some occurring in one location more readily than others. And then as far as the unsubstantiated, all that information is reported to the state in a state report in December. Anything you want to add, Jean?
No, I think that part of it is because our rights specialists work in territories, which is almost unique to the across the state of Michigan. They are very acute IR for their territory, and they do the investigation. So they have a good pulse on what's going on.
Good point. Yes. That's the benefit of having them be a part of territories. They're visiting the residential sites and seeing individuals more on a regular basis, so they have a good sense about what's going on. Any other questions?
Yeah, this is Vijaya. I have one question about supported decision making. How is it implemented, and is there a possibility of a presentation on that at some point in the future?
Sure, we can do that. Right now, the Development Disabilities Council has created a training, and we're hoping to be able to be trained in that training and do those trainings throughout our community as well. COVID kind of, slowed us up a bit. Our group does meet monthly, and yes, it is part of one of the fiscal year goals. And so if the board pleases, we could do a more in-depth presentation related to the supported decision making.
Thank you.
This is Sarah, and not so much a question, but just thank you. I thought this was very helpful. These presentations have been really great to learn more about each person's departments. And I just want to thank the three of you as well as your staff, because I can imagine there are a lot of difficult things that come across your desk, and you do very important work. And I just appreciate all the efforts from the administration and your staff. So thank you very much.
Thank you, Dr. Guadalupe. Yeah, we do sometimes have to deal with very difficult situations, but the really best part of our job is that we get to interact with the persons that we serve on a regular basis, and that makes the job worthwhile.
Are there any other questions for Vicki, Jean, or Mike? I'm assuming not, but the presentation was really very helpful. And I think that it gave a really good overall picture of how we work with the folks we serve to make sure that a lot of their lives are in a better place. So thank you for that.
And for the new board members, usually in June, we present our state report, which has a lot of details about the complaints, substantiated, how many, that sort of thing. So for newer board members, you will get that information in January after we've completed the state report.
All good. Any other questions for the team? Well, thank you so much.
You're welcome. Thank you.
Very interesting. Thank you.
Thank you.
Okay, moving on. Our next item is an overview on behavioral health home.
Hi, good evening again, everyone. I'm going to go ahead and kick us off. So if we can go to the next slide. So I think everyone's aware that OCHN has been a leader across the state and often sought out nationally for our integrated healthcare initiatives. And so last year, prior to the dissolution of boilerplate section 298, we had presented our outcomes data to various legislative bodies as well as the state that showed that our own care coordination efforts were able to achieve a 62% reduction in hospital days and a 38% reduction in emergency department days for the people whom we conducted care coordination activities for. And so we had offered our expertise in the form of section 294 to the governor's budget for last year. And it was really intended to offer an alternative to 298, which showed that you could still integrate care at the person level without having to shift the fundings from the PIHPs over to the Medicaid health plans. So staff at the state were very aware of our work and very impressed with our outcomes. And they reached out to us about a year ago and asked if we would be willing to partner with them to revitalize their work around behavioral health homes. So we, of course, agreed. And we've been working with them for about the past year on what that might look like in Oakland County. And so this is a new service line for us, as well as a new revenue stream. And it really allows us to provide those care coordination activities to anyone in our county, regardless of whether or not they meet PIHP or carve out eligibility criteria. And so the state has also really fully embraced the aspects of the OCHN model, which really promotes peer support specialists working as community health workers alongside nurses to really engage people and help them to navigate the healthcare system. And so we're very excited to be able to provide this type of service to many more people throughout our entire county. And one requirement of being a behavioral health home is for us to have an identified project lead who would serve as the primary point of contact between OCHN, our behavioral health home partners, as well as the state and any other invested stakeholder. And so Emily Patterson, who presented her research that showed statistically significant cost savings as a part of our care coordination activities, has been selected to fulfill this role. And so I'm going to turn it over to her, and she's going to walk you through the progress so far and what additional steps we need to take to be ready to roll out behavioral health homes by October 1. Emily.
All right, thank you very much, Nicole, and thank you to the board for having me today. Advanced slide, please. So a quick overview of the program of Behavioral Health Home. So the goal of the Behavioral Health Home is to provide comprehensive care services to address the physical and behavioral health conditions of individuals served. So there are 6 key services that are included in the Behavioral Health Home model. And people who will be eligible are specific Medicaid beneficiaries with serious mental illness or serious emotional disturbance. And the state has given us a risk stratification that they are using called episode risk groups to identify folks that are most at risk so that we can target who in the county we can reach out to and in what order. So I'm going to go through these 6 key services in a little more detail. Advance, please. So the first element of the service is comprehensive care management. And comprehensive care management is a holistic assessment and then later on reassessment of a person's healthcare needs at a high level. So both behavioral and physical health care needs, assessing that individual's readiness to change, and then development of an individualized care plan that you will see referenced throughout the model that orients the care to whole person care instead of segmented physical and behavioral health. And then all of that care plan and those assessments and reassessments are documented in the EHR. Advance, please. The next element of the model is care coordination. And I came to speak to you about care coordination before, so you know it's my jam. Care coordination seeks to integrate and organize all aspects of a person's care. So behavioral health care, their primary care physician, specialists, physical health services, social, educational, vocational, housing, and community services that that person might need. Advanced slide, please. And then to connect all these points in the web between providers, there has to be sharing of information. So information needs to be shared, organized, resources need to be managed, and maintain contact with that beneficiary. And there is an emphasis throughout the model on in-person contact to assist that person with everything that they might need. Maybe that's appointment making assistance, including coordination of transportation. So you'll see that some of these services have a lot of overlap because the overall goal is integration between the points of care. Advanced slide, please. The next element of the program is health promotion. So this has to do with development and implementation of the care plan to empower the person to engage with their own health care. So this involves medication adherence and monitoring, referral tracking, use of liaisons is really stressed throughout the program because it aims to elevate and showcase the importance of the peer liaison and community health workers. And then on the provider side, there's use of care team huddles and conferences to the person's benefit. Advance, please. So in order to have a person be empowered to promote their own health, they need to have connection to resources, and that has to be individualized depending on what their healthcare needs are. So maybe it's smoking cessation, obesity reduction, nutritional counseling, diabetes counseling, and there needs to be training of that person and their family and support system to activate them and engage them with the person's care. We're talking about tracking on this one too, but there's a lot more discussion of tracking in the next one. Advance, please, which is comprehensive transitional care is the next element. So transitions are a very vulnerable time for a person when they go between points of care in the healthcare system. So we need to connect, update, and hold accountable the different points of care that a person needs. And a lot of this has to do with receiving and reviewing care records, continuity of care documents, discharges, and providing and receiving notifications of admissions and discharges when a person has changes in their care. Advanced slide, please. We really want to set people up for success whenever there is a discharge or transfer of care. So it's important that there is outreach to ensure there's appropriate follow-up services. The goal of the program is to be proactive versus reactive. So they want to prepare that person before they end up in the hospital or in perhaps the emergency department. Medication reconciliation and pharmacy coordination are an important aspect, and also home visits when necessary. Next slide, please. Another element of the program is person and family support. So the BHH really hopes to help set up that person and their support system with the skills and resources that they need to engage with their own care. So this really stresses use of community supports, community health workers, liaisons, support groups, and self-care programs that the person would be set up with, and facilitating improved adherence to the treatment plan. So we really want to remove those barriers that the person has to their coordinated care. Advanced slide, please. The next element in the, oh, there it is. Here we go. Additional person and family support. The provider needs to advocate for individual and family needs, assess and increase the individual's and the family's health literacy so that they're empowered to engage with their own healthcare, and provide assistance and maximize the person's level of engagement in their social networks. The use of advanced directives is also stressed in the program, including psychiatric advanced directives. Advanced slide, please. Another element of the program is referral to community and social support services. So how can we continue to reduce those care coordination barriers and increase the person's and families' engagement skills with healthcare, and using those community supports again, which you will see throughout the program. We want to use community health workers, peer supports who have lived experience, and support groups and self-care programs that the person can engage with. Advanced slide, please. This is similar to one of the other ones I went over. As we refer to community and support services, the individual and their family needs need to be advocated for, use of advanced directives, individual and family health literacy, and maximizing that person's level of functioning and development of their social networks. Advanced slide, please. So a quick overview of where we are today with the behavioral health home program and what we have in the works. So before I came on board, there was extensive data review to determine who would initially be eligible for this program and what people could potentially benefit from the behavioral health home. We're engaged with the state on the program's design and expectations, and we meet with them about bi-weekly, but I am emailing with the state nearly daily at this point. We have weekly internal meetings with an interdisciplinary team of multiple departments from OCHN. So we have representation from clinical, IT and data side, contract, and finance, so we can address all the different aspects of getting this program stood up. And we're also engaging with our future health home partners who will partner with us to get this program running. And our two major areas of partners are our core provider agencies and Honor Community Health. Next slide, please. So how will this program actually look once it's up and running? Beneficiaries will be enrolled by us, OCHN, as the lead entity in the behavioral health home. And there's two different ways that they can be enrolled. One is the state will provide us with a list of eligible Medicaid beneficiaries, and we can reach out and enroll them that way. There's always choice, of course. And then there's also provider recommended enrollment. So one of our health home partners could contact us and say that they think someone is eligible for the program. The behavioral health home has ratios of required healthcare team members who will be in the behavioral health home to coordinate that person's care. The only role on here that is going to be employed on the OCHN side is the health home director, and here I am. The behavioral health specialist, nurse care manager, peer support specialist, community health worker, or medical assistant, and the medical and psychiatric consultant, we will contract with our health home partners to provide that staffing. Payment for the behavioral health home service is a monthly rate based on the number of beneficiaries with at least one behavioral health home service in a month. And speaking of payment, I think we're going to have Anya jump in to speak to this in a little more detail.
Yep, sure can.
Awesome. Thank you.
So as mentioned, this would be a new revenue source for OCHN and the providers that we contract with. The idea being that we would be the lead entity, as Emily mentioned, and we would push through the funding to support this. But really, we want to use this money to really focus on and put some money behind outcomes and outcome measures. And so we're working now on 2 different sets of funding methodology in order to make sure that we're covering the cost of staff in the 2 different scenarios, one being with core providers and one being with Honor Community Health, and really make sure we're covering the staff, but we're also really putting our money where our mouth is as it relates to the outcomes and the outcome measures, because that's really what we expect to see from this is significant outcomes for the people that are able to participate in it, which in the long run is a benefit hugely for individuals that are receiving services, but also helps decrease the need for additional behavioral health services from a Medicaid perspective. So we're in the process of developing that and have set up some meetings with both the core providers and Honor Community Health to continue to work through that process. As far as I know, Emily, I'm turning it back over to you.
Yep, thank you. Advance slide, please. So next steps in the process. First, engage, or in some cases, re-engage with our health home partners who will join us in the behavioral health home effort. So way back in the fall, we were in conversations with Honor Community Health, but COVID-19 put a pause on those discussions. So we are re-engaging with Honor Community Health this Thursday, June 18th. And then we have our first work group with the provider network to engage with them on June 29th. Another big area that we're working on for next steps is identifying the groups of people or the potential beneficiaries that we will contact first, because there are a lot of people in the potential beneficiaries that we got from the state. So we're doing data analysis of the people who are most at risk according to the risk stratification and finding out where they're served, both geographically and by which provider. So we're figuring out, are these folks that are already served by our core providers? Are they served by Honor, both, or neither, so that we can be intentional in how we target folks who can benefit from this service. And then another item we're working on in next steps is contract drafting and negotiation. We get new information from the state all the time, and we are hard at work on it, and I'm having a great time. Next slide. We'd be happy to welcome your questions at this point.
Are there questions for Nicole or Emily?
I have a few questions. This program is not up and running yet, right?
No, ma'am.
It's in the process.
It's not. October 1. Actually, that is a very good point. That should have been in there. October 1 is the go live date that we are working on with the state. And based off of where we are today, we're sticking with that goal.
Will this require any additional funding for electronic records, or are we compatible with everybody now with our EHRs?
So my understanding is that I think we will be just fine, because on the core provider side, they're already documenting in an electronic medical record, whether it is ours or their homegrown system, which they are using. And we've figured out interoperability, like ways to make them talk to each other for our current services for the core provider agency. And as a community health center, Honor would already have an EHR. I'm not sure which system they're on, but they would be documenting that way. Anything you want to add, Nicole?
No, other than we might have to just build out a little bit in Odin, like Emily had referenced, but there shouldn't really be cost tied to that. We should be fine.
Mm-hmm. And we have an IT subgroup that's hashing through all these considerations right now. We have folks from our data team, Odin team, talking about if any changes will need to be made and what those will be.
And my last question is, are all of the core agencies considered partners, or is this just a few?
So our core provider agencies will be given the opportunity to partner with us on this, and we expect that they will. Do you have any detail to add to that, Nicole?
No, we rolled this out to the CEOs not too long ago.
Okay.
We've got another meeting scheduled, and then we're just asking them to gather subject matter experts, just so that as we get some of the details kind of down that Emily's been working on really hard with the state, we are then kind of debating whether we're doing an amendment to current core provider contracts or whether this would be a separate provider contract. All of the providers have expressed interest. So we're anticipating that they would all want to take advantage of a new revenue stream.
Okay. Thank you.
You're welcome. Thank you, Malkaya.
Are there other questions for Nicole or Emily? Okay, go ahead.
Vijaya, my question is, will there be any additional staff required for this service? And the second question I have is, are there any accreditation or certification requirements for this service?
So to answer the first part of the question in terms of staffing, we're going to be hashing out with the partners how they can address the staffing requirements of the behavioral health program. And I know Anya and her team have been working on the financial side of it just to make sure that the rates are in line with what's realistic to get staff on board. In terms of the OCHN side, I am the only person that would be additional staffing.
Okay, and then regarding the certification or accreditation, because this is quite a comprehensive service, I mean, touches almost every aspect of a person. So are there any accreditation or certification requirements for this that the state has, or federally? What is that, if there is any?
You want me to field that one, Emily?
Please.
Yeah. Hi, Dr. Hahn. No, there is no additional accreditation required for that. The nice thing about the behavioral health home is because it's in line with a federal program. So as long as the state writes their contract in line with the federal program and we follow all those rules and regulations, we aren't required to do any additional accreditation around that.
Oh, thank you.
Yep.
Other questions?
Hi, it's Sarah. If this was already asked, I apologize. I got kicked off and got logged back on. But is there a cap on the number of folks that are able to enroll or be a part of the program?
I think it is only limited to what we can handle. So based off of what other counties and regions who have implemented this, what they've experienced, it seems like it takes off pretty slow. So we're talking like 50, 100, 150. And then from there, it's just as far as we can take it. Because we have the feeling that other providers are going to be interested and there will be potential to expand.
Okay. And I do just want to thank everyone that's been a part of this during the Community Mental Health Association of Michigan Executive Board meeting I think it was last Friday. It was brought up as an update that we were a part of this. So I think it's good publicity for the organization, and just thank everyone who was a part of getting this together.
Are there other questions?
I did have just one other question. It wasn't clear to me. Are we reaching out to people that we don't currently serve within our system? These are additional people who normally would not be in our service base.
Yes.
New clients, so to speak.
Yes. So this service is available to folks who are not necessarily currently served by our provider network or OCHN. It's just folks with who are Medicaid eligible with a specific list of diagnoses.
Okay. Thank you.
You're welcome.
So just for further clarification, they might be enrolled. So Emily, how many people in that initial data set are we currently serving? And then how many people did we have that were potential that we could reach out to?
Okay, goodness, I'd have to find it.
I'm putting you on the spot.
Yeah,
I'm really sorry.
I'll find it. It's okay.
Malkai, I want to say there was about maybe 1,800, 2,000 people that we were currently serving. And then there was another potential 15 to 17,000 people that we are not currently serving that could be eligible.
Great, thank you. And it's very exciting, the program that's coming. So thank you all for your hard work.
Thank you.
Are there other questions? I have a comment. I agree with Makaya. This is so exciting to see that you're going to have something where people are empowered and engaged in managing their own health. And I can think that that is only a positive for so many. I think that we might have much more interest than capacity, but nonetheless, very exciting. And I appreciate all the hard work that went into it. Other questions? Okay, thanks so much. The next item on our agenda is other business, and at this point I'm going to turn it over to Sarah to provide an update on the activities of the search committee.
All right, thank you, Judy. So everyone should have gotten, or I hope was able to access the documents that I uploaded to Boardable yesterday. We had our second meeting with the CEO search committee yesterday afternoon, and then as soon as that meeting was over, I worked with Judy and Edna to get those documents together and out to you. So at this point, we are at the point of providing you with a snapshot of contract topics or components that the search committee has agreed upon, or a majority agreed upon those different topics to include in the CEO candidate's contract. We wanted everyone to take a look and see if there's any questions or comments regarding that snapshot. In addition to the snapshot, I included previous CEO contracts, the CEO evaluation tool, as well as some documentation that Edna had provided to us. So Edna's been great in getting us a lot of the historical information and, market comparisons and things like that to help drive our discussions and, help us to develop the best contract that we can. So I wanted to open it up to discussion to see if there's questions regarding particularly that snapshot sheet that had kind of looked like a chart with different topic areas for the contract, and then I'll move forward from there in a few minutes. But any questions or comments regarding that? The next step after we take a look at it would be to have our legal group review it, and then once the board agreed for that, it will be presented to the CEO candidate to see if the candidate is willing to accept our contract as written. So with that being said, any questions from the full board at this time regarding the contract components that were outlined? Is it quiet? No one has any comments, or are we anyone on mute?
Sarah, I think that maybe if the board knew that we're hoping to get an endorsement of these contract elements tonight, maybe that would generate some more questions, because we do want to move forward to have the legal review.
Yes, so in order to move it forward with the legal review, we would need agreement from the board that the items that were included in that snapshot are agreeable to the board at this time, so that we can move it forward for legal review. And then, as I stated, move it on to the candidate, so that, obviously time is of the essence. As soon as we can get a contract presented to the candidate, the better, in case there is any negotiations that have to occur, any back and forth after that's presented. So with that being said, we would hope that, as Judy mentioned, we could move forward with an endorsement or agreement that what's included in that snapshot would be agreeable with the board to move on to legal, and then ultimately the candidate.
Sarah, Judy, this is Jonathan. Can I make a motion to, first to the board that I have been on that selection committee. We've gone through the due diligence process. We've presented a candidate of choice. We've now discussed across our subcommittee or our committee, our selection committee, a benefit package that we think is suitable. So I'd like to make a motion that we move forward to the next step and develop the term sheet to present to this candidate.
Thank you, Jonathan.
Is there a second for Jonathan's motion?
I'll second.
Jonathan, could I just ask for clarification? Are you including in your motion having legal review as the next step?
If that's the next step that puts together the term sheet, yes.
Okay, thank you. Are there any other members of the search committee that would perhaps like to offer some insight on their experience or their thoughts regarding the sheet?
This is Pat. I think the team worked really well together going through this. There was, some differences of opinion, but we always came with an agreement as a unanimous thought for each of the component items that are in there for some good rationale. And in my opinion, we have a very solid piece of information here that can be turned into a term sheet and put in front of the candidate.
Thank you, Pat. Anyone else that was on the committee?
Judy, this is Steve. Am I correct that the way the motion reads now is that if the board approves that it would go on to legal, and then if legal approved it, then it would be offered to the candidate, so we don't have to bring it back to the entire board again?
Jonathan, do you want to clarify?
Please. I'm making a motion that we have legal review and craft a term sheet that meets the terms and conditions we've asked for. Okay, so I don't know if they have to adjust wording for it, but I just know that we're looking forward to having, my motion is to have that term sheet approved by them so we can present it. So I don't know what I have to say around that, but that's the intent of my motion.
So is it also the intent of your motion to have this be the final approval from the board regarding this contract to be offered?
No, it's to propose the term sheet just in case there's further negotiation. I don't want it to be a final, here it is, take it or leave it.
Got it. Okay. Sarah, sure.
Oh, I was just going to say, I'm thinking potentially that, and correct me if I'm wrong, Jonathan, but that the motion would be to take our information, have legal review, place it into a term sheet and present to the candidate. So it's not a final contract, but that term sheet can then be presented to the candidate. Is that correct? Without coming back. Okay.
Yes, it's the hope that they will accept the term sheet as is.
Okay.
And we can then have legal craft the final contract.
Yeah, this is Steve. That's what I was trying to say. Thank you, sir.
And it would not need to come back to the board, correct?
I don't think after legal reviews it, unless there's something major, right? It would come back to.
That's what I would think.
Say that again, please.
I think that, taking the steps we were just walking through there, if the board agrees with the terms that are in the document that Sarah sent out to everyone tonight, then it gets turned into a term sheet working with legal to make sure it's correct. And then an offer is made to the candidate. If the candidate agrees, then it's a matter of the lawyers just putting together the contract and finishing it.
And if there are negotiations?
Well, then it'd have to come back to the board because they want to make changes.
Right. Okay.
And while I like that idea, It's been my experience that in the companies I've worked in, that if I propose a contract, the other party has to sign it, and then we come back and we countersign it for approval.
That's
So
what I
that's,
would think. That's
yeah,
sort of the process I had in mind.
but but the contract would be on the basis of this turn sheet.
Correct.
So
Judy,
Yes.
I guess I was part of the committee too, and I know that we did our due diligence with putting this together. I guess my question to the rest of the board would be, do they have any questions about the terms that we've come up with that they would want us to answer for them, or do they just agree with what we presented?
I think that's what Sarah asked as well. Thank you, Malkaya. Are there any other comments from the board?
I have one question. First, I want to thank everybody on the committee for creating the terms and working with her. They look really great, and we appreciate it. The only question I have, and this is really because I actually am not sure, for annual increases in raises, is it typical that the head of a quasi-governmental agency, since they're at the top of the, probably of the income level, that they would get the same percentage raise as, someone who, is their first year on the job or their first job out of college? Like, that percentage is quite different. So I just was wondering, is that, I'm sure you did your, I'm hoping, you did your research. Is that typical that it's the same all across, or is it sometimes different in like that higher group?
From our discussion with Edna's input, and if we need her to step in, I think I saw her on the meeting, but that only occurs when it's available in the budget, and it can range from anywhere from 1% to 3% is what it has in the past. That in 2017 there was a percentage increase, and then there was nothing again until January of 2020, and that the CEO or executive director was eligible for the same percentage as all other staff in the organization, but it was up to that person. I mean, they could say that they don't want to take it if they wanted to, but if Edna's on the call and I did not articulate that well, feel free to jump in, Edna.
So I was in the meeting. Oh, can you hear me?
I'm sorry. Go ahead, Hadass.
No, I remember that taking place. I'm just wondering, is that typical of other quasi-government agencies? Like, I know what we've done. I just wonder if that's typical. Like, even in other, nonprofits or quasi, does everybody get the same percentage across? I don't know if Edna's not on. Well, let's see if Edna's here.
I just added an item to the comments, and it's not an unusual thing to see. In the event of a decision about bonus or merit, we have had the experience that our CEOs in the past have declined any additional merit or general increase over and above what staff has received. So there's been a pretty consistent pattern that our CEOs have not set themselves above what other staff have received. And that's not unusual because you also want to take into account market considerations.
Okay, great. Thank you so much. So I'm ready to approve.
Are there any other questions or comments?
Judy, just one.
Sure.
There's two different increases listed on the document that Sarah provided to the rest of the board, and the performance bonus is separate from the general increase. And I just wanted to make sure that was clear. because the performance bonus was the one that sometimes our CEO chose to take a portion of or not to take it at all, depending on what the economic climate was at that time. Even though they may have earned the increase because of good performance, if the market didn't bear it or the budget wasn't strong enough, then 9 times out of 10 they would take a portion or not take it at all. So I don't know if that helped with what Hadass was trying to ask or not. But the other general increase was overall to everybody.
And it's discretionary.
Yeah.
Are there any additional comments or questions before I ask Sheila to restate the motion? Sheila, could you read back what the motion was, and we'll make sure that Jonathan has it, that he agrees with his intent and what we have it gotten kind of convoluted here. Is Sheila talking to us? I'm not sure quite what's happening here.
She is unmuted.
Okay.
So, oh, I see. She's got the unmuting that she's doing so that she can try to speak.
Great. Super. Thank you.
You're welcome.
Did you read?
Are we still muting, unmuting?
She is. She logged off and she got back on.
Okay. I do think we do need a restatement of the motion, just to be clear.
And I could try that.
Do you want to
Can you
wait
hear
for
me?
Sheila, what Sheila has, and then tweak it, Jonathan?
She's there now.
Okay.
Go ahead, Sheila.
Okay, can you hear me? Okay.
Yes.
I've got, motion was made to approve CEO contract terms as presented with moving forward with seeking legal review and offering contract terms to CEO candidate by Mr. Landsman and supported by Ms. Newman.
That is my motion, yes.
Is there any further discussion? Is everyone clear on what the next steps are? Sheila, would you call the roll, please, then?
Yes. Okay. Mr. Furman?
Yes.
Ms. Guadalupe?
Yes.
Ms. Bernard?
Yes.
Mr. Torres? Mr. Lindemeyer?
Yes.
Ms. Namie Dyer?
Yes.
Mr. Landsman?
Yes.
Mr. Kemp?
Yes.
Dr. Hans?
Yes.
Dr. Taub?
Yes.
Ms. Newman?
Yes.
Ms. Summers?
Yes. Thank you, Sheila.
So, Judy, can I just follow up with a couple quick comments?
Certainly.
Okay. I just wanted to get the motion out of I don't want to say off the table. Moving forward from the motion. So along with the previous contracts in that term sheet that I had uploaded, there was also the evaluation tool that has been used in the past for annual reviews of the CEO. And so with the contract terms that we have just agreed upon, there is a component of that performance bonus. And so according to, and again, we'll have to kind of make sure that legal and the candidate agrees with this, but according to the way that we have it written, is that the terms of that evaluation tool or the goals are going to be required within, now I can't remember, 30 days of hire.
30 days or something.
I was like, was it 30 or 90? But 30 days of hire, which means that we are going to need to take a look at the current evaluation tool that is out there to see if we think that there needs to be any changes or, you know, how we want to do this. But I think it's going to be very important that the goals or the objectives are set forth very clear and making sure that they're measurable as we move forward. So I'm hoping that perhaps we'll have time in the near future at potentially a board study session that we can take a look at that tool a little bit further to get input and see where everyone's thoughts are regarding that evaluation tool. But just to keep in the back of your minds that we do have to have that tightened up and ready to go within 30 days after the hiring of the new CEO. So with that, any questions or comments regarding that process?
Sarah, this is Steve.
Yes.
Just for the new board members, we used a similar tool to this, but last year we completely revised it when we did a last evaluation. We got rid of some questions, added some new questions in, and then changed the rating from what it was before. So it ought to be pretty good. I think it always bears looking at, but like I say, it's only a year old. It was perfect last time we used it. So that's all.
Thank you.
Hey, Sarah, this is Pat.
Hey, Pat.
I took a look at that. I assume this is the most current one that Steve's referring to, where it says evaluation of the executive director 2018-2019 prepared by the board evaluation committee.
Yes.
Correct.
I think in questions 2 through 10, I would suggest whoever is going to work on this that there needs to be more tangible measurements. I think all the areas are right on, the questions themselves, the overall questions, but there, you know, as we're working through this, we need to put some actual teeth into it as far as tangible scores, because it seems to be rather subjective. And, you know, that always gets you into a trap when you're evaluating someone. You got to have some subjectivity, but most of it is, you know, based on this, did you accomplish that? And, you know, and measurable, you know. So I just recommend that to the board as we're going through this. I think you really want to get it so it can be very measurable. And almost every 2 through 10 seem to be the ones that were open for the possibility of doing some type of measurements.
So
Yeah,
very
I would
quantifiable.
agree. Yep. And
Yeah.
I think potentially looking at them is, I was just trying to pull it up here. Instead of, a lot of them started with how satisfied are you, and maybe taking that language out and looking at statements instead of a person's satisfaction, because I think that just lends itself to be a little too ambiguous. But something I think that just warrants further discussion and review. Doesn't need to happen tonight, but as I said, potentially at a board study session or something, just as long as we get that done, I think the sooner the better, to kind of work on that before we hit that 30-day mark.
Yeah, let me piggyback on that, Sarah. My plan was that we would look at this at the study session as part of the agenda. The study session is next week, June 25th. And that we begin the discussion, we can continue to tweak it at the committee of the whole in July for final approval at the July board meeting, because we do have a time frame to follow. So if people would continue to look at the survey tool to see what tweaks they think would make those items, the criteria that's embedded in that survey tool, measurable, so that it is substantial enough to warrant the awarding of a performance bonus, I'd appreciate that, but we can start that conversation next week when everybody's had a little bit more time to look at it, or I guess even if they have other ideas. But I think, as Steve said, I think that the core areas identified in the current tool are solid. And looking at the language and how to measure might be a topic for a good discussion as part of the study session next week. Thoughts?
Yeah, Sarah, Judy, this is Jonathan. I am definitely a fan of that. Whether we had a 30-day requirement or not, it's fair to the candidate to know what they are going to be measured on for the next year, or actually the next 3 years. So identifying not just the what's, the 10 items, but also the how's for each one of those. So how do we quantify whatever each one of those items is? So that's what Pat was saying before.
Agree. There's a lot at stake.
And one other comment is, should all these be weighted the same when you're coming up at a final score, if you will? That's something to think about. Maybe some's a little heavier than the others, or maybe not. Maybe they're all the same.
Yeah. And I think just, again, taking a look at it and being prepared to see if there's anything that could be missing, if there's other goal statements or metrics we need to look at. But I agree with what everyone else has said and look forward to have further discussion in the coming meetings. So I do, though, really quick, I just want to thank everyone that was on the committee and those that took a look at the documents overnight. I know it was last minute. Again, I appreciate your time. And I continue to say and will say to Edna and Anya, thank you so much for everything. I don't think we would nearly be as far as we are today without all of the information, historical information that you've provided. Just so happy to have you working in collaboration with us. So I really appreciate you.
Thank you, Sarah. That's not Edna, but thank you for that statement. I agree. I think that the committee worked very, very thoughtfully and very carefully. I appreciate all the energy that went into it as well. And as Sarah said, without Edna's historical point of view and kind of market sense, we wouldn't be where we are right now and having something ready to be reviewed by legal, having the term sheet ready. So thanks to everybody who has been involved. I appreciate it. The work's not done, but we've made, I think, pretty good strides. The finish line is in sight. So before we leave other business, I just want to go back to the study session. We will have a study session. We'll keep it at our regular time. Part of that session will be the discussion of the survey tool and if it's what we want to use as a basis for the determining the criteria for the performance bonus that we're offering. And also Anya wants to do a kind of in the weeds version of the fiscal year budget, fiscal year 21 budget. It's in draft form, and so that'll be the other part of the presentation. So is everyone okay with that? I'm going to take that for a yes and move on. The next items are the reports from the committees. Jonathan Wrights.
Sure. The Recipient Rights Advisory Committee met virtually on June 4th at 4 o'clock. Richard Zemark was our facilitator. Vicki Suder, our Director of Rights and Advocacy, who you heard this evening, along with Gene Fender, Mike Daly. But Vicki provided the following updates. This is old news to all of us that the OCHN board has selected a new CEO. That's Dana Lazenberry. Dana has worked in a number of roles at Detroit Wayne Integrated Health and the previous names of it, Detroit Wayne. So we are working on the term sheet. So that's old news because we just passed a motion to move it forward. But also that the anti-racism statement that was issued and distributed, she asked that we all take a look at it as well. And the last point of information is that the Your Voice, Your Value conference will be virtual and it will be held on August 17th. So that's a Monday in about 2 months from today. Gene Fender, who's our manager of recipient rights, provided the following updates. The OCHN building, using social distancing, is going to be opening on Monday, June 15th for managers and leadership. It will be open for staff, for those that can't work remotely, starting next week on Mondays and Wednesdays, or Tuesdays and Thursdays. And the office will be closed on Fridays to all, with everyone working remotely. The other item is that she's working, well, not she and her team are working on the development of an updated secondary trauma training and trauma-informed interviewing for the ORR rights specialist in access, and as well the customer service team. And they plan to use an outside speaker. The details on the training will be shared once it's final. The other is last month I had reported, and we had all reported, that complaints were about even year over year. But actually, since COVID, there's been a slight decrease in the number of complaints received. And again, since that was the department of discussion tonight, they covered a little bit about complaints and the process, et cetera. And then as well, Vicki and Jean also talked about our progress on goals. One of the goals is to generate ideas to bring a greater awareness to a person's rights of those we serve. The feedback we receive from this goal from the work groups and surveys seems to fall into 3 areas: the fear to speak up, or the fear to file a complaint. It's 1. 2, individuals don't know how to file a complaint. And 3, that individuals feel that they aren't taken seriously because of their illness. So the next steps by Jean and Vicki and their teams are to discuss the education of peers. Another RRAC goal is to find ways to educate guardians about the rights that persons served have. So, and we've had this as an ongoing topic on our agendas there, about how do we do that outreach, because guardianships and guardians are not part of our circle. They are actually managed through, I believe it's family court or probate court. So that's a world that's outside of ours. While we could go there, we don't really have a legal standing in that space ourselves. So it's a question of, how do we influence them? How do we help them understand, what are the rights of persons served, and how do we help guardians understand that and become more cognizant about that, and the judges as well. So one is to invite guardians to attend our training. Another is to create training for the guardians. Another is to do a mailing to guardians and to the courts to provide that information, so that in turn can be provided to them. I know we've created a number of different pamphlets. Those are provided to them. We don't know to what extent those are passed out, distributed, or read or used. The last is to attend at an AMORC meeting, which is the guardianship training meetings. They had been happening on a pretty regular basis at the county courthouse, but those got canceled due to the stay-at-home order by the governor. So we'll find out when those get resurrected again, and hopefully we'll be able to get on their agenda and present. Another item, the next thing that we typically do at our RAC meetings is to review existing policies, look for improvements, understand what the value is to them, et cetera. So we covered policy 9.1, which is about abuse and neglect. And it's important to note that for abuse and neglect issues, those cases that are reported, we handle them quickly to get them to identify if there is a case there, that if it holds merit, and to basically resolve them ASAP. So the question that was raised was, could that be included in some of the upcoming training for people that are getting recipient rights training? And so the curriculum will be reviewed. And then the next item was site review data. As you know, we report that out every month. As of the beginning of May, 41% of the sites had been reviewed. Due to COVID-19, Some of the site reviews had been postponed or delayed, but the goal is still to complete those by the end of the fiscal year. And then the last item on my list was previously the BEST, or the anti-stigma group, had delivered in-person 30-minute trainings, but again with COVID-19, they shifted their gears to say, is there another way they could do outreach? And so they've been providing stigma wellness tips at virtual work group meetings and at committee meetings. So anyhow, so Vicki asked if people could write messages of hope, encouragement to combat stigma. She also asked, what do you think we can do to help make people feel more positive about themselves? And the responses were to smile, to go above and beyond to help someone out, to remind them, to ask them what their strengths are, to ask them to make a list of their accomplishments, to just listen and spend more time with someone, and to call them by their name. It's amazing the strength of a name, which is why earlier tonight when I said Pat, and I really meant Patrick, because that is his preference and that's what I call him by, but I had to apologize because I didn't. So as usual, we don't have a July meeting, so the next Recipient Rights Advisory Committee will be held on, and I think it will be virtual, but it will be Thursday, August 6th at 4 p.m. And that's my committee report.
Thank you, Jonathan. Are there any questions for Jonathan regarding his Rights Advisory Committee report?
Yes, this is Vijaya. I don't have a question, but I have a comment for the rights training or training of the guardians. If that can be done online, probably will be more useful, because a lot of the guardians, I suppose, live outside the area, or maybe their work schedules are such that they may not be able to attend an in-person training or information session or whatever. So that was a comment.
Dr. Hunt, that is an excellent idea. And I will bring that back to the committee to see if we can't, video or create a webinar that could be replayed at their convenience.
I think that's an excellent suggestion, Jonathan. Thank you.
No, thank you.
Any other questions or comments for Jonathan? Thanks so much for your report. The next item is the report of the Citizens Advisory Committee. Malkaya?
Yes, Judy, our committee is meeting tomorrow morning, so I don't have a report, but I have been asked to come and give an update to the committee as to where we stand with our process of hiring our new CEO. So I'm on the agenda to report out to the committee where we stand.
Okay, thank you. Should be a more comprehensive report than maybe it might have been, huh?
Yes, much more.
Thanks. Are there any suggestions or comments for Malkaya to bring a message to the Citizens Advisory Committee? Okay, thank you. Eric, did Oversight Committee meet since the last report you provided?
No, our next meeting is going to be on August 12th.
Okay, great. Thank you. We'll move on then to the director's report. Anya?
Okay, everybody. So as you all know, we regularly make verbal commitments to not only you all as the board, but our stakeholders, our providers, and the people we serve, that we always put people first. And what we also know is that the words coming out of our mouths are not what builds trust and confidence. It's really seeing us in action and the actions that we do over time that really makes people believe us and feel like we're doing those things. So as you're all aware, in the coming months, our Deputy Executive Director and COO, Dr. Nicole Lawson, is drafting our annual plan, which is really our roadmap for the next year and ties into our strategic plan to kind of start to focus on what things we want to accomplish in the next fiscal year, and what things we want to make sure are a priority and where we want to be a year from now. And that's really with the focus of people's input. As you're aware, we've sent out surveys. It's been presented at board meetings. I believe we've sent out roughly 25 to 25,000 individuals and 400 service sites. And we want to continue to get more and more feedback as we are able to do so. So we encourage all of you and every one of our stakeholders to provide input into that, because your voice matters for this and all community conversations, not just specifically to our annual plan. As was mentioned earlier, our board chair, Judith Summers, and I put out a statement that reflects our values on racism and the oppression of others that included a pledge to work at ending racial and ethnic biases. So the same as before, people are going to want to see that put into action, because again, saying that is one thing, but really putting that into action and demonstrating that we really believe in those things is really how you get people to understand and believe you when you say things. And so just to give you an idea of some of the things we've already done related to that is we've had 3 internal discussions with staff to talk about racial disparities and self-evaluations related to that and what we can do to improve as an organization. And now we're in the process of thinking about how do we strategically implement those, who can help facilitate those. And this is, a network and a system that is not new to discrimination and stigma. And so one of the values we hold very dear as anyone in this organization, and as you all do, is that when we show up, we speak up. And so we ask that all of you do that by leading by example with dignity and kindness. And, we've seen the strides we can make in the public mental health system with people believing their value in the world and their that they deserve to have the same rights as everyone else, and we believe that across the board. So knowing the passion that this industry has and that its advocates have, I'm sure we can do the exact same thing to eliminate racism and move that forward. That's it. Thank you.
Thank you, Anya. That was a very important message. Are there any questions or comments for Anya regarding her director's report?
Judy, I have one for Anya. The work that the staff did around identifying areas where they could make a difference in terms of racism, is that something that's going to be shared with the board?
So I'm sure it will when we get it a little more together. We just got the summary information today, and so we're putting together a plan on what to do next and kind of what steps that entails. And yes, we can definitely bring that kind of information to the board as to what we're doing and what people really wanted to see from us as an organization. Sure.
Okay. Thank you.
Yep.
Would it work to provide that in an update, Anya?
Certainly.
Okay, maybe that would be a good first step, and we can have more discussion if necessary.
Yep.
Any other questions or comments for Anya? Okay, thanks so much. Our next item is our second opportunity for public comment. Christine, has there been any comment made?
No, we have not had anyone sign up for public comment this evening.
Okay, thank you. Thanks for being on standby. The next item is board member comment, and I'll have Sheila go through the roll, and if you have a comment, please share.
Mr. Kemp?
Good meeting tonight. A lot of information. Really good news about the financials turning around. Hopefully we can keep that going. Thanks, everyone.
Mr. Landsman?
I just want to thank the search committee. I know I was part of it, but the rest of you that were part of our team, we worked hard. We're in the home stretch. Hopefully we'll have Dana coming on board in the next few weeks. Maybe, I don't think it'll be by July 1st, but I'm sure hopeful. Thank you.
Dr. Hahn?
Again, a very good meeting. Especially, I want to thank Anya for her director's report, her comments, very, very important. And also all the hard work that the search committee has done under, these very difficult times. But I think they have to be congratulated for a job well done. Thank you.
Dr. Tom.
Yeah, thank you again, awesome staff and Anya for persevering under these hard conditions. And then just in general comment, I think that we're really lucky and America is really a strong country. And I think we can recover from the COVID-19 we take the vaccine. And I will have one by the first of the year. And they're also manufacturing 8 or 9 different vaccines. I think that not only will we have one, but we'll be able to supply 100 million doses right off the bat. And then for the other problem that's been going on for a lot longer than COVID, anybody that has 2 eyes, 2 ears, a heart, a brain, or any combination thereof has to have been woken up to the inherent built-in racism that lives in people's hearts and the hate and evil. And I think now that everybody's aware, I'm a conservative. I believe in a level playing field. We certainly don't have that. I think we can have it, and we need to be kind to each other and listen to each other. And I think we'll get through this. It won't be as long as we think. That's all.
Ms. Mamie Dyer.
I just wanted to say thanks to Jean, Vicki, Mike, and Emily for their presentations as well. It's really nice to hear about all the different moving parts of OCHN and to hear about the progress with the behavioral health home program. I think it's really exciting to see the progress that's consistently being made to the services offered. So thank you for that. And then just kind of to follow up on what Pat said regarding the CEO evaluation, I would love to be able to provide input. Part of my experience and training is to come up with measurable criteria and performance metrics for employees. So if it will be helpful, I'd be happy to give input for the next meeting. But I think all of the documentation that was reviewed for the CEO was very well put together. So thank you.
Mr. Furman.
Yes, I would just like to again underscore the presentations for tonight. Really enjoyed the rights, advocacy, and customer service presentation. Once again, providing a nice overview of another one of our departments. And also, echo the previous comment, it's really exciting to hear that the behavioral health home is on the horizon and on schedule, despite all the things that the staff and the network that deal with these last 3 months. So I'm encouraged. Thanks a lot. Have a good night.
Dr. Guadalupe. I will just quickly say thank you again to everyone who did the presentations. I think it continues to be very helpful and easy to follow with the financial updates, as well as learning about the different departments. So thank you to all the staff for making sure that all of the individuals we serve are taken care of. Thank you.
Ms. Bernard.
I want to thank the staff very much for all their work in the presentations today. They were really wonderful. And also, it really was a very good meeting, extremely positive. So it's always exciting to hear really good news. I really think it's great, Anya, that your director's report talking about what you're doing for your staff is very exciting. And thank you, everybody. I agree with all the other board members. Thank you.
Mr. Torres. Mr. Lindemeyer.
Hi. After the last meeting, I didn't get a chance to call whoever made the decision, how much I appreciated the fact that we took a 46-second moment of silence for Floyd. I'm afraid that blacks in America are going to continue to get killed by the police unless we all remain vigilant. Long after the cameras go away and they move on to a different subject. This issue of racial injustice. I mean, I'm 57 years old. It's been going on, you know, a hell of a lot longer than I've been alive. And we have to make sure that we move forward and that there is serious institutional change. And it's all of our responsibilities to make sure that we're not only looking at ourselves, but we're talking to our neighbors as well. We cannot be a healthy community as long as somebody in our community is hurting. We'll never be what we should be. I hope to God that someday it'll change, but I'm afraid that we're going to turn on the news tomorrow and the next day and the next day, and there's going to be another black person killed by a police officer. And I hope that someday it'll end. Thank you.
Ms. Newman?
Thank you, Eric, for your comments, and thank everybody for their comments. This has been an extraordinary time. I'm 67. I just turned 67. And I was born in the 50s when Brown versus the Board of Education came out, when all of the riots and protests took place through the 60s, the 70s, the all of that. And I never dreamed that we would be at this place where I can honestly say, and I believe that we're on the brink of permanent change, because it had to come from other people other than people that look like me. I was in Southfield Sunday where they had a Took the Knee rally in Southfield, and it just boggled my mind that it was people there of every ethnic group, religion, and they were all in unity. There was nothing negative going on. And to have people that don't look like me say Black Lives Matter, that did something to me. And I truly believe that we are at a turning point. I truly believe that we will no longer be able, it won't be tolerated, because it's too many people that are watching. Even if cameras aren't rolling, people are watching, people are looking, and people are speaking up. So I have faith, and I believe that this country is going to one day be what the founding fathers said it would be, that we were all created equal, and we will all be able to pursue life, liberty, and justice in this country. And I believe that we are on the brink of that. What happens after this, I have to hold on to my faith and my belief. I thank God for the opportunities that I've been given. I appreciate this organization so much. Not just because I've sat on the board here, but because I work for a court agency, but I came through the doors as a person in need. And my life was altered in ways that I just can't express. And that's why I cry so much, because I've been changed by this system, by this organization, by the people that work here. And that's why I want to do everything that I can do to make sure that we're the best, not just in a few things, but in everything. So I appreciate every board member. I appreciate the staff. I thank God that we're having board meetings that are productive and uplifting and positive. and that we're coming together in ways that we couldn't always do it before. So I thank you for giving me the opportunity to serve with you, allowing me to speak my heart and speak my mind and not take offense to things that I've said. And I do believe that it's going to stop. It has to stop. There's too many mothers crying, too many wives crying, too many children crying over people who have been lost. And I believe this is the end of it. And I thank you all, and you all be blessed, be safe, and have a good night.
Miss Summers?
Why do I follow Melchiah? This is probably an effort and futility on my part, but I just have to say that everybody has been so eloquent in their comments tonight, and that I continue to appreciate the effort and commitment and sustained work by everyone who is working so hard to support all people equally. Thank you. If there is no other business, we are adjourned. Good night. Have a good one.
Good night, everybody.
Good night.
Night.
Hey.
Good night.
That's